Hi, and welcome to the final webinar on our matchmaking event. Once again, my name is Diogo Henriques. I'm working with Porto for Aging from the University of Porto in the IN-4-AHA consortium. So to close off this week, we chose to delve in the very current topic of telehealth and healthcare systems resilience. Telehealth is not a new phenomenon. Video consultations and home monitoring tools have been around for a while, but time has passed, and more sophisticated and more able to provide quality care to users and patients in the comfort of their homes have started to emerge. To value these tools has made even more evident with the emergence of COVID-19 pandemic. The Europe-wide confinements have proved the need for health systems to develop alternative means of care, diminishing the reliance on person care in a cost-effective way, helping them to better understand the current and future crisis. So to discuss these topics today, we have the contributions of Florina Truta, José Bastos, Alberto Sánchez, João Magalhães, Alberto Sánchez, and Daniel Stan. So to introduce a bit on our guests today, Florina, which will be speaking today, has a background in pharmaceutical sciences and has contributed with experience to multiple organizations, including first Fresh Blood Health Tech, and more recently Fourth Tech Investments and the Connect project. She will present us with an overview of the state of the art in telehealth and telemedicine. Then we'll have a blog on best practices in health that will feature 3 exemplary innovations on this stand. So we'll have firstly Daniel Stan, which is CEO at Femyo, which is Europe's first healthcare marketplace for women. Then we have João Magalhães, a digital entrepreneur from Knok. Knok is a leading fully integrated telemedicine platform that features video consultations, robust data safety and safety specifications, and the possibility to fully integrate patient pre-existing data. Finally, we'll have a presentation from Alberto Sánchez. Alberto is the head of e-health at Gradiant. Gradiant is a company that develops communication technology based on connectivity, intelligence, and security. In the field of healthcare, they have participated in many EU-funded projects such as Persist, developed mental health apps, and other digital tools. Afterwards, we'll have a Q&A session, so you can use the chat box to drop your questions or do so live during the Q&A. As always, the session will be recorded and uploaded to our social media channels. That being said, thank you all the speakers very much. And Florina, you can now take the floor. Thank you.
Thank you, Diego. I will share my screen. Just a second. Can you see my screen? Okay, so hello, my name is Florina Truta, and I'm a project manager at Fresh Blood Health Tech from Romania, and also a member of Connect project. And today I'm going to discuss the main aspects regarding telemedicine. But firstly, I want to tell you a few words about Fresh Blood, which is an NGO that supports Romanian health innovation. At Fresh Blood, our vision is to improve the healthcare through people, projects, and partnership to become the go-to place for innovators from Romania and Eastern Europe, and to transform the healthcare system with tech innovation. At Fresh Blood, we are involved in many national and international projects, and the Connect project is one of them. This project is focused on e-health innovation, training, and education of students to improve their knowledge, help them to develop cross-sectoral skills and competencies, entrepreneurship mindset, and support the critical thinking required to improve the healthcare system. Maybe you are wondering what is the history of telemedicine? Well, in the United States, one of the early use of telemedicine was established by the NASA in 1960 for monitoring astronauts in flight by physicians and medical teams during their mission Project Mercury. So what is telemedicine? According to the World Health Organization, telemedicine represents the delivery of healthcare services where distance is a critical factor by all healthcare professionals using information and communication technologies for the exchange of valid information for diagnosis, treatment, and prevention, as well as research and evaluation, and for the continuing education of healthcare providers, all in the interest of advancing the health of individuals and their communities. Telemedicine is also a part of e-health which is defined by European Commission as tools and services that use information and communication technologies to improve prevention, diagnosis, treatment, monitoring, and management of health and lifestyle. Telemedicine can include a broad range of services like telemonitoring, teleconsultation, tele-expertise, and teleassistance. On the other side, mobile health or mHealth is closely linked to telemedicine. This term covers medical and public health practices supported by mobile devices such as mobile phones, patient monitoring devices, personal digital assistants, and other wireless devices. As shown in this picture, all forms of telemedicine as well as mHealth are part of eHealth. As I mentioned before, telemedicine is divided in 4 subcategories as follows. Teleconsultation that occurs between a health professional and a patient. This is a therapeutic or medical act carried out remotely with or without the presence of another health professional next to the patient. On the other side, telementoring happens between 2 or more professionals without the patient presence, and it includes diagnostic acts and second opinion. Telemonitoring happens when health professionals are remotely check and monitor the data of a patient. In this case, data are collected outside the hospital setting by the patient, by another health professional, or automatically through a monitoring device. Last but not least, teleassistance is a practice occurring when a physician remotely guides a medical act, for instance, a medical procedure such as imaging or surgery. Regarding the telemedicine market, in 2019, the global market size was 27.8 billion, which is expected to grow in the next 10 years and to reach 144.2 billion in 2030. The major factors driving the growth of telemedicine industry are the rising of geriatric population, the increasing prevalence of chronic and lifestyle-associated disease, the increasing of the healthcare cost, the increasing of the government funding and grants for telemedicine, and also the growing needs for remote patient monitoring services in the developing countries. But what are the benefits of using telemedicine? In the case of doctors, the main telemedicine benefits are the possibility of increasing their revenues because video visits are more efficient than in-person ones. This means that each provider can see more patients during the same period of time without needing an office space. Also, another benefit is represented by the scheduling flexibility. This could be another benefit for doctors because telemedicine technology can be used virtually anywhere and anytime. This gives them the option to offer extended hours or even weekend operations without requiring the physical office to be staffed. By using telemedicine, patients are more likely to comply with recommendations for the follow-up appointments if those recommendations can be conducted via video. No-shows and last-minute cancellations are big profit drains and time wasters for doctors. These frustrations can be mitigated with the help of telemedicine by eliminating many of the factors that cause them, like transportation issues or the need to be at work. From the patient's point of view, the main benefits with using telemedicine are no transportation time or cost. When you see your doctor on your mobile device or computer, you can save both money and time. No need to take time off work. Speaking of work, video visits largely remove the need to take time off. You can simply schedule your visit during a break or before or after work. Also, many of us have the responsibility for caring for children or older adults. Finding alternative care so that you can see the doctor can be difficult and expensive. Fortunately, telemedicine solves this challenge by allowing you to see your doctor while upholding your family responsibility. Also, another benefit is the access to specialists. If you want to see a specialist and it's not in your town or not in your region, it's very difficult sometimes to arrive there or to drive there 2 or 3 hours. But by using telemedicine, you can have access to specialists that are not in your region. Another benefit is that with telemedicine, there are less chances of catching a new illness or spreading yours, because you don't have to wait in the doctor's waiting room with another patients. For the hospitals, the main benefits are earning additional revenue by enabling physicians to conduct at least some appointments via live video. Health system can attract new patients who aren't able to drive 4 hours every time they need to talk to their doctors. Another benefit for hospitals are the greater community visibility by offering virtual visits, robust mHealth apps, and innovative remote patient monitoring solutions. Health systems attract positive media attention and new patients. Another advantage is the boosting of staff productivity. If there's one thing doctors and nurses don't have, it's spare time. Efficiency and outsourcing are among the key benefits of telehealth for hospitals. And by using telemedicine, they could improve the patient engagement and satisfaction. Despite of the fact that telemedicine has many benefits for all the stakeholders, there are also some challenges in implementing it. The main barriers in the use of telemedicine are the reimbursement and the interest of healthcare payers and insurance providers, because when a patient avails healthcare services through telemedicine system, insurance claim may not cover the cost of care as it is not delivered through traditional healthcare system. Also, licensing for using telemedicine is another problem, because in order to avoid malpractice in telemedicine as a doctor, you should be specifically trained for telemedicine as they do for traditional medicine. Poor availability of experts and trained professionals raises legal implications and difficulties for telemedicine providers. Another issue is represented by technology and usability. There is a serious lack of such technical persons who can run day-to-day business of telemedicine. Also, there is a lack of confidence in the patients about the outcome of telemedicine, and it's difficult for them to believe that machine can provide healthcare demands without visiting a physician face-to-face. As you can see in this picture, telemedicine use was shifted from using it just for overcoming the geographical constraints to using it for increasing the customer satisfaction, customer retention, and brand value. Telehealth 3.0 is about consolidation, integration, interoperability, and purposeful planning. It is about having a single, easy-to-use, secure, integrated virtual care platform. Regarding the adoption and usability of telemedicine, the results are promising. 2021 marked the first year in which live video was the most used telemedicine modality among live video, text messaging, email, messaging via in-health app or website, and picture or video messaging. With this slide, I want to emphasize the fast-paced development of telemedicine solutions and the competitive market that was created around this concept during the last years. Now, I will give the floor to Daniel, CEO at Femyo, a telemedicine solution from Romania. Daniel.
Thank you, Florina.
Thank you, Florina, and hello, everyone. Femyo, so basically my company does a very simple thing. It gives doctors the tools to offer telemedicine or teleconsultations, basically, and online appointments and audio or video consultations for, common things like repeated prescriptions or common paperwork that you get from your doctor. And it's going okay now, but it was a long journey to get here. So from Florina's presentations, you saw the definition of what telemedicine is. and you saw how it's organized, across the globe. But when we started, we had the same idea that, it will work the same everywhere. And we quickly learned that what works in the United States, it might not work in Europe or in Romania specifically, or our previous experience in Southeast Asia brings basically almost no value to the European landscape. So it took us a while until we learned that we have to actually work very closely with our doctors and to deeply understand how patients actually interact with the medical system and how they actually receive telemedicine. Because the idea was that basically almost nobody offered telemedicine like 3 or 4 years ago. There were only a few providers like us. And we thought, this is a virgin market, basically. But then we realized that it's not really like that at all. Doctors like GPs or family doctors, like we call them here, give a lot of telemedicine consultations every day. So maybe 10 or 15 every day. But they do it over the phone, or they do it in text messages, WhatsApp, and so on. So we had to adapt to the way they actually work. And they gave it for free. So that was also a thing that influenced our decision to move from directly offering services to patients and move towards offering tools for doctors. So what we did was to create a system that integrates the doctor's phone system, so the actual phone line, with an online, with a web page, basically, with online appointments, with common information, with the goal of helping the doctor save time, so he doesn't repeat the same messages over and over to hundreds of patients every month. He doesn't waste time doing appointments over the phone, and he has the tools to actually monetize what the insurance company doesn't cover. And that actually worked a lot better. So once we started working with doctors directly and offering them exactly what they wanted, it actually started going well. Like I said, the fallacy in our initial thinking was that video consultation will work in Romania. People don't care about it. Or paid consultations will work here. It's a very limited market. What works is, calling your family doctor and asking him for a prescription or some documents or over a quick advice over the phone. And that's basically what telemedicine means here. And I think that's my advice to anyone looking into starting a business in telemedicine, is that you shouldn't look at what Americans are doing or what people in Southeast Asia are doing. You should take a very deep look at the medical system in the country you're targeting, whether it's your home country or another country, and try to really spend a few months understanding the system, because it's very different from actually doing interview with doctors or patients. They will say video calls are great, everyone wants that, but then you see nobody's using them because it's just much easier to place a regular phone call, especially if that is reimbursed by insurance. So the learning is that you should really personalize it to your country. And another learning that we have is that you should use cheap technology. So you shouldn't rely on, so our first iteration had an iOS app, an Android app, a website, and each of that had its own front-end developer, which didn't do any work on. So the iOS guy didn't know any Android, and so on. And that costed us around $100,000 to develop. And it wasn't good at all because it just costed so much to adapt it every day that it wasn't sustainable. So we switched to cheaper technology. The phone system is no way to avoid it. It's based on Asterisk, which is an expensive developers market, technology, whatever. But for the rest, we used cheap stuff like WordPress. And our apps, we put them on, on a web platform. So now we can adjust our system basically with every doctor every day. So if I get a new doctor today signing up for our service and he says, I want this thing tweaked a bit here because my patients in the countryside or whatever don't have the patience to actually go through this entire form or whatever, they work like this, we just adjust it immediately for them, and then we can sell that modification to another doctor. And it just works better like that. So constantly adapting. So even after a year and a half, we make changes every day. So we still make changes every day, and I think we will continue doing so for a while. Although every investor you will meet will say you should make a product, define it, whatever, fix it, and then sell it to 1,000 people. It just doesn't work like that in telemedicine in Southeast Europe, at least. So adoption will be an issue to everyone trying this. Doctors are not really willing to give video consultations, for example, because first of all, they don't want to be filmed while they give bad advice. It happens. So they don't want any proof of that. And, a phone call is just so much easier for them. They don't feel like it existed. It's just 1 minute, it can't go wrong. So adoption from doctors' part will be a problem. And then adoption from patients, if it's a paid system in Europe, medicine is free in, I think, all countries in Europe. So asking for money is going to be tough. So adoption from the patients will also be tough unless it's something that they're really familiar with, like phone or SMS. We even integrated WhatsApp for a few doctors. So we use, common WhatsApp business with a few tweaks that helps them monetize outside the office hours, or do a little triage. So if a new patient asks for something, we do a questionnaire. We ask for like 5 questions about what they want. So the doctor doesn't have to spend, 5 minutes on WhatsApp trying to find out what's wrong with that patient. So we basically went really low with the technology. So I see a lot of EU funds and a lot of programs focusing on deep tech. I strongly discourage deep tech in the beginning. So you should start with the lowest tech possible and make it work. Have doctors using it, have patients using it. So to give you a bit of background here, our system is used by more than 100 practices, and each has 1, 2, or 3 doctors. And last year we had about 10,000 requests for doctors, so forms filled in online, and something like, I don't know, each of them has almost 1,000 calls every month, which went through our systems. So it does, scale up, but that doesn't mean we're at the stage where we can say this is a solution for everyone. So I think until we reach at least 10 or 15% of the total number of doctors in the country, we won't have a product that we can easily say, this is something for everyone. Like I said, systems in the US, for example, or in Southeast Asia are very different. So my experience in Southeast Asia was that medicine almost didn't exist. It wasn't free. Doctors were very far apart, even in cities. So whatever you gave them was good enough. In the US, it's the opposite. Medicine is widely available, extremely expensive. So there, the cost is a very important factor. I have friends which have similar businesses in India. It's a doctor's market there. So there are a lot of doctors with very small practices. Everything is paid usually. So their interest there is to monetize. So yeah, when you're building a telemedicine company, you should look at what the market actually wants. You shouldn't try to impose a system that works somewhere else, because almost certainly it doesn't work everywhere. So in Europe, every country has a different medical system, and they might look similar because it's free for the patient, but the way it gets, health gets reimbursed, or the way doctors are paid, for example, in the UK, you're paid a fixed amount per patient, and it doesn't matter how many consultations you have every month. So basically, doctors try to get away from all the consultations because it's just a waste of time. They still get the same money at the end of the month. So there, every telehealth system in the UK just tries to push as much of the work to online, to AI, to whatever, so they don't see the patient in the practice. In Romania, it's half-half. You get half of the money just doing, nothing, and half of the money for consultations. So doctors, try to keep a minimum of consultations every month, but everything above that, they try to get rid of. In Poland, they actually get paid extra for teleconsultations. So everything they do is towards increasing that number of teleconsultations. So it's really, I'm not sure how it's in Portugal, but it's really creative in every country. So lawmakers really got creative. So you really have to see what the average honest doctor actually wants to do, if he wants to get rid of the patient or if he wants to help the patient. And it's a very matter-of-fact thing. It's a very, when you talk about health, people are sensitive about it. They don't want to say, I want to get rid of the patient. So you really have to have a close relationship with the people who you're interviewing. Otherwise, they will just tell you, I answer to everyone at every hour, whatever, I'm a great doctor. But if you invite them to a beer, they will say, I'm exhausted, I can't take this anymore. I'll quit medicine if I get a single call tonight. So you really have to look at who your client actually is. In the beginning, for us, the client was the patient. Now the client is the doctor. So we adapted everything for them. I hope this gives you a bit of insight on how things happen, at least in Romania, if not in most European countries.
Thank you very much, Daniel, for your very honest presentation. So now we are moving on for, I believe, João. Yes, João.
Okay. Hello, everyone. Just a quick intro. I'm João. I am one of the co-founders and CTO of Knok Healthcare. My academical background isn't actually in engineering. I'm a medical doctor. I don't practice anymore, but I always try to fusion both technology and medicine. And this is why we have co-founded Knok, and that's what I'm going to talk about. Let me just share my presentation. So we believe that everything starts with a purpose, and we use this as an internal guide and also an external guide. And we want to be the go-to platform for digital transformation in healthcare, and to be accessible to as many people as possible, and to try to reach the utopia of universal healthcare, so that everyone has access to healthcare. We believe in many things, and especially in the decentralization that is occurring in healthcare services. So we are moving more from the physical, and going more to the digital. So the patient journey is going towards this digital first paradigm. And also that the decisions will be more and more data-driven. These are some of our beliefs. We have others, such as privacy and not selling the patient data, and be very protective about it, for instance. And above all, we care for the patient life, and this is what we aim at now. Some of our numbers: we are the telemedicine leader in Portugal. But we are also present in other 11 countries. We are very strong in Latin America, also Southern Europe, and we are entering in the market in India. We have more than 200,000 appointments. more than 3,100 active doctors and 5.1 million people covered by our service. So with all our clients, we are covering this number of patients, which is a pretty huge number. We sell the platform mainly with two business models. One is B2B. So we have a software platform to do digital monitoring and consultations. And we also have a B2B2C model where we own the medical network. So we work these two ways, and we are able to define clinical models by having our own doctors. We have 86 Net Promoter Score, so the patients really like our platform and the experience with our doctors. And we have 14 languages, and we're growing every day. The type of clients, these are some of our clients, and I would categorize them as hospital groups, insurance companies, health systems, national health systems, and also clinics. So we are able to serve all these type of clients. What we aim at is, it's where I want to get at the end of the presentation, is for you to get the idea that this goes way beyond a video consultation or a phone consultation. So there are many other things that can help practicing preventative medicine. This is what we believe, and this is where we are trying to get at. So we are gathering data from thousands of interactions being previously to the consultation by the patient filling a questionnaire, by gathering vital signs from either smart devices or even the patient's own laptop or smartphone with the camera. That's possible to do, and we have that technology. Also with triage, both human or AI triage, and also appointments. And here we are gathering more data, and we are creating this. We are delivering digital healthcare. So we are providing healthcare through digital means, and we aim at being the reference in that area. So this is the evolution that we have seen since we started practicing telemedicine. So we went from the first stage where telemedicine was an alternative to connecting over the phone or for reasons of accessibility. We went to this stage 2, more or less previously to the pandemic, to the COVID, where we started gathering more clinical points during the video consultation and actually being a tool to do early diagnosis, so to practice primary care. Also started doing some research in machine learning in order to try to prevent some acute cases in the patients, especially on the chronic ones. And now we are in the phase of product development where we aim at arriving to the stage 3, where the primary care will be digital first. So this will be the entry point. We will have the connected devices, 5G, which will increase the quality of the video consultations, and also the latency, the diminished latency, which will give better decision support systems for the doctors. We will practice prediction and prevention by giving doctors tools for signaling these potential acute cases for patients, and we will reduce the clinical error. This is the stage we are at, and to arrive there, we believe that healthcare will become more and more will be referenced to a value-based care model. What does it mean, value-based care? It means that the providers are incentivized to take care of the patient outcomes and also to reduce costs. This aligns the incentives both of the patients and also for the payers. Why? The payers want the patients to lower the costs, and the patients want to have better health. So here you are incentivizing both of them. And we believe we are building the platform that allows this kind of financial model in healthcare. So as you can see, there are many chronic conditions that are preventable, and they are preventable by being more controlled with these digital tools. So we can do that by having appointments regularly in a specific program, also taking their vital signs, gathering more structured data through PROMs and PREMs, and we have the tools to do that. So how will we help, and what we have now? So we have this video consultation telemedicine platform, and these are some of the modules where we have an AI symptom checker. We also have a human triage in this case. We have the appointment scheduler. We have payments integrated, vital signs readings through the camera, as I said, with a technology called remote photoplethysmography. We have file transfer during the consultations or before and after. And we have the electronic health record and the electronic prescription. Of course, the electronic prescription varies according to geography. And the last module that we have been adding is the ability to send and process PROMs, PREMs, and calculate scores based on that. PROMs are patient-reported outcomes measurements. PREMs are patient-reported experience measurements. And scores are such like cardiovascular risk of a patient that allows the doctor to flag some problem to the doctor and make him act on that. These are for you to get an idea of the flow. We have here a flow that starts with a human nurse. So this is a human triage, where there is a phone call is received by our nurses, and usually it's for someone who is looking for a home appointment, urgent appointment, and it goes through all our triage, which is aided in some steps by AI engine. And then at the end, the patient is suggested either a video appointment, phone appointment, home appointment, or head to the emergency room, or also calling an ambulance, because we have already avoided some cases where the patient would die if you would get a home appointment. So we avoided that as well. We not only can convert some appointments to video consultations, but also we provide better care by doing this triage. Also, the patient is able to book a consultation by himself, starting with the symptom checker with the AI engine, and also going through all the stages until he gets the video consultation. At the end, he's asked to rate the experience, hence why we have the information regarding NPS. And the doctor fills out the electronic health record and prescriptions. This is the technology I was talking about a while ago. We are able, through the camera of the laptop and the smartphone, to gather vital signs. We gather signs such as heart rate, respiratory rate, and also the blood pressure categories. This is something we are still working on to improve. So through all these interactions, we have at the moment more than 30 clinical data points per consultation, and this number is increasing and will increase even more with integrations. And this allows us to predict, to get some risks on the patient, and at the end fulfill that value-based care dream of reducing costs for payers and improve health outcomes to the patients. So in order to get this data, we have also a fully integratable platform, which is really important. And it works in web applications and also mobile applications. And this is all white label, so hence the licensing commercial model that we have. And what we propose with all this system, mainly by using the triage, as I explained previously, is to have this clinical pathway optimized. And we have data. We are applying this program in Portugal with a base of about 800,000 patients or more, about 1 million. And here the numbers that we have so far is that 85% of the primary care cases are solved by video consultation or phone consultation. This is pretty huge number, and also we are able to optimize this pathway by channeling people who would get home consultation and would get care just like 3-4 hours later, and they are able to access a doctor much faster with us and get their problem solved. which is really important. Also, as I said, we are able to sometimes to make the patients go to the hospital directly, and thus avoid any sequela for those. How will we improve on these metrics? So to get these operational gains and clinical gains. And clinical, of course, the clinical quality is one of our main goals here. Here we want to follow the patients, the chronic patients, and by following them with good clinical practice and good digital tools, we want to be able to avoid acute events to these chronic patients. An acute event would be an heart attack or a stroke, for instance, for an hypertensive patient. And this reduces the mortality, reduces these acute events, and thus it reduces costs and improves patients' lives. This is our main goal. And in this study has already been made in the USA, where they decrease the cardiovascular risk scores by following these patients digitally and continuously. And we aim at doing this, at applying this kind of model. So we identify the risks by analyzing the clinical data, using prompts, and then we'll reach out to those patients via a nurse or a doctor with specific treatments. These are some of the data that we gathered through our consultations as well. We, for instance, one thing that's curious is that 42% is between 18 and 44. So this means that most of our appointments are out of that range. So it's we have about 30% of video consultations from patients above 65 years old. So the accessibility is increasing by a lot. This is something important to take into account. And these are the diagnoses that we detect during our consultations. 15% are chronic, 30% are acute, 15% are also for admin reasons, such as prescription renewals or sick leaves, and 60% require a face-to-face appointment. And our resolution rate, as I said, is really big, and NPS as well. This is an hypertension case that we have in Portugal, where we detected in a pool of patients which ones had a high risk, and then we addressed those high risk factors for cardiovascular disease, and we reduced the global risk to the insurer with our health program for these hypertensive patients, and we improved treatment adherence, and we were also improved the medical attendance, and thus getting better clinical outcomes for these patients. I'll show later what outcomes did we measure. This is some of the programs that you can see, and it's based on prompts and also on measurements made by nurses and also by the patients. The first appointment, we get all the clinical data, and after we get the blood pressure, 7-day chart blood pressure, and the anxiety prompt. And then we do all these subsequent appointments where we will gather data and have a continuous program for these patients. They are accessible, as I said. They are sent via SMS, email, and they are web-based mostly, and so it's easily accessible by everyone. And we have seen that we are able to reduce the costs by a lot, because with us, it costs around 20 euros per month per patient to be followed, and the cost that these patients, the cost of these patients not being followed is between 260 and 1,000 euros. So it's a pretty big difference. Some of the outcomes that we measure during this program that I said before are the adherence, the quality of life, autonomy, adherence to the therapy. So these are all things that are measured through these continuous programs. All this is only possible by having data as our North Star. And we call this, and data must have the 3 R's, as we said. So it must be reliable, and must be research directed, and must be relevant to the medical scientific staff and also to the operations. So having this in mind, we have a data warehouse, a very strong data warehouse, where the data is anonymized, is analyzed, aggregated, encrypted, fully GDPR compliant, and we are able to extract clinical and operational insights, and also to open this data warehouse for research purposes. So we have partnerships with the medical universities here in Portugal, and also we are able to do our own research, because we are a company which is recognized for doing scientific research in this kind of technologies. So we are using that data to try to create some predictive algorithms and see new opportunities for flagging and helping in decision support for doctors. These are some of our dashboards. These are operational dashboards, which are important to track doctor performance, and also the appointment average durations, the classification, the reviews, to have these operational insights, and also healthcare insights, such as analysis of ICD-10 codes, have different patient profiles, many other kinds of clinical insights, such as COVID trends or disease trends during time. All this, of course, based on being compliant with European Union rules. So we need to be certified as a medical device. We are on the process of doing that, both 2A and 2B. And also being fully compliant in terms of security, and hence we are at the moment doing the ISO 27001 certification, which is really important for showing to our clients and to our patients that we really care about cybersecurity and security processes. This all flows into an ambitious roadmap, where we aim at investing in patient service, also doctor-patient messaging, doing some research work on video emotional analysis during the video consultation, improving on our vital signs readings, also aiming at doing better integrations and integrate with more hospitals, clinics, and being able to gather more data, quality data, in order to, at the end, practice value-based care by identifying risk patients and acting on them and improving their healthcare. So thank you very much. This is my presentation.
Thank you very much, João, for your presentation of the incredible work that Knok is doing, and congratulations. So now we'll move on to Alberto Sánchez. Alberto, the floor is yours, so you can start any moment.
Okay, I'm sharing my desktop. 1 second, I need to launch the presentation mode. So good afternoon, and thanks, Diogo, for giving me the floor. Also, thanks to IN-4-AHA for inviting us to this event and giving us the opportunity to share with you one of our projects in which we are working, which is Persist. Well, as you know, my name is Alberto Sánchez. I'm the head of e-health at Gradiant. We are a technology center located in the northwest of Spain, in Vigo, in Galicia. And our main goal as an organization is to enhance the technical capabilities of the industry in Galicia first, and then in Spain and in Europe, by providing solutions for connectivity, security, and intelligence. We work in different areas, for instance, in industry, in advanced communications, and also in health. And this is the area that I'm leading. And today I'm going to introduce you one of our projects called Persist. It's a ACE 2020 research and innovation project, whose main goal is to create and validate a care plan for cancer survivors, taking advantage of technologies such as big data and artificial intelligence technologies. And well, I would like to start with some numbers regarding to describe which is the epidemiological challenge behind Persist and why we are working in this project. And basically, we can see that the number of cases in cancer cases in Europe is increasing every year. We have like 4.5 million new cases in Europe last year. This is the bad news. We are having more and more cancer cases, but the good news is that the survival rate is growing even faster at a pace of 3% per year. And at the end, this is good news, but it's also putting pressure on healthcare system, on the healthcare systems that are now under pressure by the COVID situation, by many other situations, and it's producing this pressure and for a healthcare system which is not ready maybe to support those patients and to meet their needs, which are very special and that for cancer survivors, and that are and they become a long-term patients that require a lot of attention during a long period of time. Okay, so in order to address this problem and targeting this epidemiological shift, a partnership between 13 partners from all over Europe across 10 countries was created, and it includes technology centers like Gradiant, also universities, SMEs, national patients organizations as well, and big tech companies, also hospitals, that are aligned in order to address this problem and try to find this care plan that can support this patient. We focus on the problem from a human standpoint, and we wanted to focus on which are the challenges for patients and also for professionals. On the one hand, in the challenges for patients, we identified many, but these are the three more clear, and we think they cover the most of the needs of these cancer survivors. One of them is the toxicity of the very aggressive treatments that they have undergone when they were diagnosed with cancer, and also the side effects, after effects, and also the secondary diseases that appear as a consequence of these treatments. And they include, for instance, cardiological problems and also malnutrition. Then another challenge for patients is the recovery of a healthy and active lifestyle that they should keep in order to prevent these secondary diseases and also to improve their quality of life after the bad times they have had while being treated with chemotherapy or other aggressive therapies. And finally, also the psychological support to accept their new situation, to deal with the fear to recurrence of cancer, and also accept some of the body changes that may have been produced, for instance, in the case of breast cancer or in the case of colorectal cancer, where they have to wear a stoma for the rest of their life. And obviously this has a remarkable impact on their emotional status. We also address the challenges for professionals. We identified that the main problem is the poor coordination between different healthcare levels. There are not specific clinical pathways for each cancer survivor. Also, the access to data is limited between different care levels. Also, there are not, in addition, there are not individualized care plans for each kind of cancer and each patient, and this should be addressed. And also, there is a lack of specialists. We have very good oncologists in Europe, very good experts in the field, but they cannot cover the whole population of cancer survivors. And what we think and what we identify is that some other professionals should be empowered to be able to follow up these cancer patients after survival and be able to take decisions, clinical decisions, to treat these patients and support them. What we propose in Persist is this survivor care plan based on 3 pillars. One of them is data capture, intelligence, and also decision support. Data capture is structured in an mHealth application that is provided to patients so they can feel more engaged and committed to their own care. Then we have also, we are capturing data from electronic health records, and here interoperability played a very important role, and I think this is one of the biggest barriers for telemedicine and e-health systems in general. And we decided to use the standard FHIR in order to guarantee the interoperability. Then we also have the second pillar, which is intelligence. We built a platform that merges artificial intelligence and big data in order to predict the worsening of patients, also adverse events, also the risk for depression. And one important remark regarding the project, and I think I wanted to comment it because I think it's a breakthrough technology and important improvement in the assessment of cancer using artificial intelligence is the analysis of wet biopsy lab images, where we are able to count and classify the circulating tumor cells, which are a good predictor, both the count and the classification of those circulating tumor cells, in order to predict the recurrence of cancer in these patients. And finally, the last pillar is the decision support. We are providing physicians with tools, with a tool to visualize the data of patients, and so they can perform a more close and more timely follow-up of patients. And also the artificial intelligence is creating some alerts that they can receive in a web application, and they can get more information, get those alarms, and react timely when worsening of the patient or a risk of worsening is detected. Regarding the technology, we wanted to show you also the mobile app. As you can see, the patients are provided with a mobile app, also with a smart band that records data and captures data about the heart rate, the blood pressure, also step count and sleeping patterns, which are is valuable information for the people in charge of these patients. And also it allows the mobile application allows the assessment of the emotional state of these patients by the emotional wheel, which is a tool that is used to assess the emotional state. The aspiration of the project is to also incorporate a new technology, which is the assessment of the emotional status by using artificial intelligence and video recording. So the patient will record themselves with the mobile phone, and our algorithms will be able to identify when they are in risk of depression. And finally, the application allows also the visualization of data, so patients can see their own trends, and also the care plan that has been created specifically for them by the physician in charge. Then another module is the web app that the physicians are using in our project, that allows the visualization of the data collected by the patients, and also the alerts that are generated by the artificial intelligence, and they are able to see all the alerts and react in a more timely fashion and take clinical decisions with this support from the artificial intelligence. This is the timeline of the project. As you can see, it started on 2020. During that year, we worked on the co-creation of the application. We engaged patients and professionals in the creation of the technology to get the adoption, to increase the adoption of the technology. Also, we developed each of the modules, we integrated, and we focused an important part of the project at that point was interoperability as well. Next year, in 2021, we worked in the data capture and the training of the algorithms that will predict the worsening of the cancer survivors, and also we worked on the usability and user experience. We had a pilot with 160 patients using the technology, and we assessed the usability and trying to improve their experience while using the technology to maximize the adoption of technology. In this year, in 2022, we are still capturing data and training our algorithms as well. And finally, in the last part of the year, we will have a clinical study with those 160 patients in order to assess which is the clinical impact of our new care plan and validate it with respect to regular cancer survivor care. And the project is expected to be completed by February 2023. Then, well, the patient feedback is very good so far. They have highlighted that they feel more engaged, that they feel that they are more cared, and that they have more autonomy to participate in their own assessment, and they feel that they play an active role in their own care. They have highlighted another functionality that they would like to have, which is the social networking, and we think this is important because to create a community of patients that are in a similar situation can be very positive in order to overcome all the barriers and all the emotional impact that they have after being diagnosed with cancer. And finally, we wanted to make a reflection on how the importance of these kind of models of how technology can have a positive impact for healthcare systems in with this and the capacity of healthcare system to adapt to the new requirements of the society. We have seen it with COVID, that we were probably not ready to tackle this kind of situations. Well, maybe no one was tackled for that in the world, but also to the epidemiological shifts that we are observing, either with cancer survivorship, but also with, for instance, the aging of the population. And we think that these three pillars, that data capture, intelligence, and decision support, are very important in order to facilitate the prediction of worsening of patients, of the occurrence of adverse events, for instance, recurrence in the case of cancer and depression, and in order to build and facilitate and enable a more proactive care approach, which is also more personalized for each case, and enabling an early intervention. This way, we will avoid costly interventions like hospitalization, rehabilitation, and will reduce the burden on the healthcare system. Also improve the clinical outcomes and improve the quality of life of patients, which maybe we don't put the focus on that many times because we cannot measure it with euros, or we cannot measure it with the time we have saved, but it's also important. And finally, also, regarding the situation that we are living, we think that these three pillars and using technology to support these pillars, it's important to understand new diseases, like, for instance, the post-COVID syndrome. You know that many patients that have overcome and are cured of COVID still have the symptoms after weeks or months, and there is little knowledge about what's the trajectory of those patients, how to treat them, how to manage these problems for them. And we think that the technology can help create this knowledge base and empower physicians and professionals which may not be experts in this field to understand the signs and symptoms, understand the patients, and create those plans and treatments that can better respond to the needs of those patients. And well, that's all. Thanks for your attention, and here you have my contact details. If you have any doubt, well, we know we will have a Q&A now, but if you want to learn more on the project, on the projects that we run, the technology that we support, just send me a message, and we will be happy to answer your questions. So
Thank you very much, Alberto. So I've seen that there were a few questions so far that have been answered already by João and Daniel. I would ask the public to raise their hands if they have any other questions to us today. Okay. Or to write them in the Q&A, just a few moments. Okay. Okay, so if that's not the case, you can always either contact directly for our speakers or to contact us and for us to put you in touch with the speakers that we have today. I'd like to thank again to everyone that participated in this series of webinars, and more specifically to the speakers that we had today that presented us some amazing products and projects. And again, all sessions will be posted to our social media networks, including YouTube, in the IN-4-AHA channel. And in the name of IN-4-AHA, thank you again. Keep innovating and integrating new technologies in healthcare. Thank you all, and see you soon, hopefully.
Thank you.
Thank you very much. Bye-bye.
Powering the innovation for active and healthy aging.